Welcome to, I'd got on my notes the 8th, but I was talking to Jeff and we actually can't remember what number seminar this is. We ran a lot of them during COVID, and it's nice to see so many faces in person, because for our Healthy Futures seminar series, this is the actual first one we've had face to face. So it's lovely to see so many faces. So welcome. Yeah, we can. So welcome to our seminar today in the Deakin Science and Society Network Healthy Futures seminar series. My name is Neera Bhatia. I'm an associate professor at the Deakin Law School, and I'm one of the stream leaders of this Healthy Futures seminar series alongside my colleague here, Professor Jeff Craig. I apologise for the croaky voice. I do want to let you all know it is nothing sinister. It is just a cold. It's nothing other than that. The Science and Society Network, to give you a little bit of background, was formed in 2018 in recognition that scientists and humanities and social science researchers need to work together to meet some of the greatest challenges of this century. No single academic field can bring about these changes that we need to see in the world. And bridging disciplinary divides is the key to finding new solutions to some of the problems that we face today. Science and Society Network supports early and mid-career researchers across the university who are embarking on groundbreaking interdisciplinary projects. I'd like to begin by acknowledging the Wurundjeri people of the Kulin Nations, the traditional owners of the land on which we are gathered today. We pay our respects to the local people for allowing us to have our gathering here on their land, and to their elders past, present and future. For those of you that have not attended one of our seminars today, just a quick run through of how this seminar will run. I'll introduce our speaker shortly, Professor Ainsley Newson. Ainsley will speak for around 30 to 35 minutes, and then we'll have some discussant comments from Associate Professor Rosalind McDougall, who's with us today, and Professor Jeff Craig. And then we'll throw to general questions and a Q&A from the audience. So I'm delighted to introduce Professor Ainsley Newson. Welcome. A Professor of Bioethics at Sydney Health Ethics, Sydney School of Public Health at the University of Sydney. Ainsley has worked in bioethics for nearly 25 years, holding positions in Australia and the United Kingdom. Her work draws on backgrounds in bioethics, law and science, which critically considers how genomic and reproductive technologies should be used well and in research, clinical and population health settings. Ainsley leads the ethics programs of research within the Australian Reproductive Genetic Carrier Screening Project, Mackenzie Mission, and Australian Genomics. Other ongoing projects examine ethical aspects of the use of genomic technologies in prenatal testing, commercial influences in assisted reproduction, and mitochondrial donation. Ainsley sits on a range of committees that deliberate bioethical issues in a policy context, including the Australian Health Ethics Committee and the Regulatory and Ethics Working Group within the Global Alliance on Genomics and Health. Also, Ainsley originally hails from Melbourne here, so I'm sure she's happy to be here, even though it's a bit cold, and relishes any opportunity to visit. Over to you, Ainsley.
Thank you, Neera. Good morning, everybody. Just going to start a timer. Okay, so thank you so much for that warm welcome, Neera, and thanks to everyone here in the room and also online. It's great to see you, and thank you for the invitation. Neera has just acknowledged country, but I would also like to acknowledge that I'm visiting Wurundjeri land. I actually grew up on Wurundjeri land. I now live on Gadigal country in Sydney, and I also pay my respects to elders past, present and emerging, and acknowledge that it always was and always will be Aboriginal land. So I'll just get stuck in. I'll start with a bit of scene setting around precision in health more generally, just where things are in Australia at the moment and more globally as well, and kind of what some of the key drivers are for my presentation here today. So what we're seeing in technologies like genomics and other omics is that they are rapidly mainstreaming. And what mainstreaming means is that these technologies are coming out of quite specialist use in dedicated clinical environments to being used more broadly in general practice, in obstetrics, in neonatal intensive care, in general practice. And there is significant enthusiasm for doing this. And actually, in several use case examples, it's making a very significant measurable difference. A good difference, I should say, too. But as well as those clinical environments, we're starting to see an increase in the use of this type of technology and the information that it generates in public health contexts as well. And this is where we're starting to see terms like precision public health. And some of the examples there are called stratification of screening. That is, we can use genomics and other omics technologies to help us determine who might need greater screening intervention or perhaps less screening intervention. And perhaps also taking the data that this type of testing generates and looking for more than what you initially thought you wanted to see. And that's known as opportunistic screening. All of these things have got their own literature, which is big, vigorous, and highly contested. It's not my job today to resolve those debates, although I'm interested in all of them. There is also, particularly for precision public health, some nascent ethical consideration in this area, and I acknowledge others that are working in this field as well. So within public health or precision public health more generally, I'll get onto what I think that might mean in a moment. But what we're also seeing is some things happening in the background that I think are informing where we're at the moment and why we're getting to the point we're getting to. The first thing is that we are starting to think about health in a much broader way. We're thinking about health in terms of wellness rather than just absence of disease. Again, I acknowledge the definition of health per se is a contentious thing and its relationship with illness, disease. There are many epistemic questions here which I can't resolve in the context of this seminar. But what is happening is that we are starting to more deliberately look for things. And there is an appetite for doing that. And that appetite has numerous drivers, not least people's own interest in information about themselves, where they came from, where they might be going, what this means for their loved ones and their families. And particularly for genomics, Emma Caval's in the audience and she will attest to this as well, is that there is a lot of enthusiasm in government for genomics. And again, I don't mean that necessarily in a critical way. It's interesting, but sometimes it can mean that there is a certain framing around these things that it's worth stopping and drawing attention to and noting. And it can mean that certain funding streams are more available than others, for example. And certainly at the moment, we are having funding streams dedicated towards using technology in health in Australia. And this is underpinned by quite a bit of advocacy that happens from interest groups and patients, and that's happening at numerous stages of the life cycle, including before birth. So, for example, the Mackenzie's Mission Project, which I'm involved with, and then increasing tendency towards thinking about use of omics technologies in other areas, such as newborn population screening. And there is also a significant commercial presence. We have a hybrid healthcare system in Australia. We have Medicare item numbers and activity-based funding. Medicare item numbers are awarded federally. Activity funding happens more at a state level. And it is the articulation of these and deciding what gets funded by whom and when, where commercial presence has a stake in that alongside other health providers. So that's just kind of how I see where we're at. And that's maybe one of the reasons why things like precision public health are beginning to be talked about in a more significant way than they have been previously. So this is what I'm going to talk to you about today. There's sort of three broad components to my seminar. First one is just to kind of collate some of the terminology and definitions. Now, I haven't made any of these up. I've just looked at the literature. So there will no doubt be people watching this seminar who are more embedded in this literature than me. And but I do that just to sort of show you where this is coming from. And also, then I get into the more normative parts of my presentation, which is, well, how should we be thinking about precision public health? And then how should we be thinking about ethical questions in public health? Now, I think I was invited to this seminar today because of a paper that I wrote that came out last year, and actually it's just now come out in an issue. And that paper considers the value of public health ethics as it applies to newborn population genomic screening, which doesn't exist yet broadly, globally. There's one or two use cases where it's happening, but there will definitely be pilot projects coming out over the next couple of years. And so the third part of my presentation mirrors that paper, which I cite at the end of my presentation alongside some of the other literature that I've looked at. So let's just first look at some of the terminology. So on this slide are just some of the terms that I've seen. And some of the debate that problematizes precision public health tends to say, look, there's nothing new here, folks. This is just a natural extension of what we've been doing for a long time. Depending on where you are in the world, you might be thinking about this in different ways, using different words. So the first two, precision public health, is definitely in use in Australia. In fact, it's kind of attributed as a group in Western Australia is attributed as kind of expanding the scope of this term and really getting it into the literature, in addition to a couple of US stakeholders. And then precision population health is also a term that gets used to illustrate the fact that really we are focusing on populations and groups and their distinction from individuals and their distinctions from each other. And the final two terms on that slide are ones that tend to be used in places like the United Kingdom, for example. And I think it's quite interesting to sort of look at those words and look at what they mean. We've got two that use precision, two that use personalised, and that sort of mirrors the debate on precision medicine more broadly. So mapping that and working out what those terms mean, which one might be preferable, is important. Again, I'm not going to do it. I feel like all I've done so far is tell you what I'm not going to do. But it's just worthwhile knowing that if you're interested in this topic, it's worthwhile searching for more than just one term. So there have been numerous attempts in the literature to try and define what we mean by precision public health. I've got a few here to bring to you. It's about tailoring. So it's about taking something that would otherwise have been a one-size-fits-all approach and trying to make it more applicable, but doing that at population scale. And so it is matching an intervention to the characteristics of the particular population that's in front of you. Now, obviously, what's interesting here is, places like Australia, we're really heterogeneous. That's not necessarily going to be a straightforward thing to do. We're also a population that has really entrenched disparities around social goods and health. And so we need to be very mindful of those, not least, of course, and including our very long-standing Indigenous cultures. This is a definition that has come from that group in Western Australia, and they talk about taking existing technologies but using them more precisely to describe and analyse people, to again tailor that word, interventions for groups to improve population health. So the goal is improved population health, and we're doing this using technology to try and specify and measure in a much more granular and precise way. And then Nguyen Curry, who is a very big name in this area in the United States, talks about improving our ability to prevent disease and promote health, reduce disparities. Again, that's a key tenet of public health. To, again, technology as a method to measure and to, again, target. So we've got lots of tailoring and targeting, groups, precision, technology. So they're all, really interesting definitions and quite wordy. The more popular definition is taking that kind of idea of precision medicine and expanding it, the right intervention to the right population instead of the right patient at the right time. So you're probably sitting there turning all of those over in your head, having some reactions to them. Just let that sit with you. One of your first things might be, I don't buy that at all, or that's deeply problematic, or that's really fantastic, what an amazing thing to do, or you might be somewhere between those two extremes. But where we are kind of coming to is it's trying to bring together principles that have been used traditionally more clinically with more public health thinking, and also bringing in a lot of the power that comes from harnessing big data, big epidemiology, machine learning, etc. And also the fact that doing these types of things, this type of measuring, is a lot faster and more accurate and cheaper than it used to be. And the figure on this slide just explains that a little bit more, and that comes from Gemma Bilkey and colleagues, a WA group. And so the ultimate game is to come up with targeted prevention at the population level. And so what they discuss in their paper is, I think something that it's important to emphasise, is that precision public health is not just about genomics. It's also not, it's about lots of other types of measuring in individuals to try and discern differences to apply group level interventions. It's not also used in just the context of complex common disease. It's used also around infection. And so there's been a range of papers come out since the COVID-19 pandemic to talk about precision public health for tracking epidemics and pandemics, and the ways that we can use this type of data to try and target specific interventions. Okay, so that's kind of a whistle-stop tour into terminology and how people are talking about this. And so I guess one question, just to depart from the slides for a moment, is something like newborn preventive screening using genomic methods actually precision public health? And in the paper I published, I do kind of make a claim around that being a form of precision public health. And I used that as a case in point to talk about how we might approach some of the ethical issues. But I'm just going to step away for a moment and make the first claim that I promised you in my abstract, which is that when we think about precision public health, my claim is that it's not just taking precision medicine and plonking it up to population scale. And there's two reasons for that. The first one is a set of practical considerations, which I think it's really important that we bear in mind when we're doing ethical, legal, social analysis of these types of topics. That is that we've got certain limitations to what these technologies can do, and that actually risk prediction remains incredibly complex, way too complex for me to even understand. And then I'll go into that in a little bit more detail in a couple of slides. And then I also think there's some ethical considerations as to why we can't just scale up precision medicine. And one of these problems is that it risks entrenching an individualization, that is, seeing a population as merely an assemblage of individuals and neglecting a lot of the overarching social considerations. And those two things kind of inform each other. So let's just take a look at those in a tiny bit more detail. So genomics is awesome, obviously, and has made a really big difference to lots of people in Australia and globally. And it's doing that rapidly. It's the technology is advancing all the time. Our genomic knowledge is always increasing. But they still remain a poor predictor of how our health is going to go. Generally, there are certainly use cases where genomics has made a very big difference. I hesitate to use the word life-saving because I don't think that we can sort of use it in that ambulatory sense. But, genomics can make a big difference to people's health. However, there's 3 dot points here that show it's not everything, and we really need to bear that in mind when we think about these types of technologies. So a lot of genomic predictive information remains inherently uncertain. Sometimes it introduces uncertainty when certainty was sought. There are also potential considerations such as variable penetrance and expressivity. And Jeff will be able to correct my ideas about thinking about these. It's a long time since my genetics degree. But this idea is a gene may not always lead to pathogenic disease in a person, and there will be other modifying factors involved. And then also how that gene expresses itself in a particular individual might vary as well. So we might have the same gene change or mutation, but whether it presents in us at all, or if so, how it does, is going to be different. And we're not very good yet at knowing that. And that can lead to all sorts of difficulties when we want to give people information that we're expecting them to take action on. We also know that the databases we use to interpret genomic information are not great in terms of diversity, particularly ethnic diversity. I want to also be clear that this is a problem that the science community is well aware of and is much more than previously now taking active steps to do something about. but they still remain relatively poor overall. There are also massive international efforts to develop databases that will ameliorate some of this. But again, just going back to my earlier point about Australia being a very heterogeneous population, this is something that we need to be very mindful of here. And we also know that a lot of these reference databases were taken initially from populations of people who were symptomatic for the condition that they were recruited to give a sample for. And we also know that these types of tests can give rise to harms. And that is harms through perhaps telling people some information that is actually variable in penetrance. And so someone takes action on that information, not knowing that actually it was never going to present in them. And it's very hard to predict that. And that leads to considerations around overdiagnosis, overtreatment, overintervention. And I think we're at just the very beginning stages of knowing what that looks like in genomics. There are certain examples in the literature, but I think there's a whole lot of people out there that maybe are just walking around feeling or knowing that they're going to get something that actually might not be as bad as what they thought, or they may never get it at all. And it's that question around the trade-off there is, well, how do we decide what is an appropriate harm-benefit trade-off around the number of people we're willing to tolerate giving that information to versus the number of people that it would definitely benefit when we cannot possibly know that in advance. So ultimately, these are some of the absolute limitations of the science at this point in time. And also we need to be careful about conflating clinical and public health use. In a different context, my colleague, Dr. Lisa Dive, and I have published a paper about reproductive genetic carrier screening. And we talk here about the tensions that come up between clinical and public health ethics. And I'll pick up a bit on that in the later part of my presentation. But with Lisa and I, what we're talking about is the fact that so much of the interpretation of this very complex information needs a family history. And if you're applying omics or genomics and other omics at population scale, the type of offer that you're going to do is going to be massively resource intensive if you are needing everybody's family history as well. And so for that, then, we need to be really careful about assuming that a test that we currently use in a clinical context can just be brought up to population level, because I don't believe that to be the case. So I think I've alluded to most of these points already. We just need to be careful about assuming utility. We need to be careful not to conflate data as being the same as information, and definitely not the same as knowledge. And my PhD student, Belle Holmes, is exploring some of those sort of taxonomic differences or semantic differences around those terms. And we need to be careful not to allow technology or technological imperatives to drive our activity here. And also, we know that genomics and other omics and technology in health generally is a very hyped thing, and it has a distorting effect on how we approach debate. And Tim Caulfield, for example, is one who's written extensively about that. We can pick up on that in the discussion if we have time. The other point here is around complex risk prediction. So this is not an area that I'm an expert in. This is just me synthesizing some of the literature. But what those who know more than I do say is that precision public health overlooks the fact that, what we're talking about here is we're making populations predictions. And so we can't predict necessarily what's going to happen to a specific person. What we're saying is for people like you, this is what might tend to happen. And individual factors actually account for much less variation in health than we initially thought. And structural factors like living conditions remain a much more important predictor of human health. And so what we need to do is, if we're thinking about precision public health or precision population health, we need to link that to what public health is all about. It's directed at populations. We focus on prevention, although that can get contentious depending on which application of omics you're talking about for the human life stage. So if you're talking about prevention and prenatal intervention, you need to be extremely careful. But we're talking also about being collective as opposed to individualistic. And we need to think about both the level and the distribution or equity around health. So much public health activity is directed towards ameliorating inequitable health outcomes in populations. So I said I had 2 points here around this claim that we shouldn't just be going straight from precision to precision medicine to precision public health. And the other one was an ethical point around neglecting the social. And Taylor Robinson and Key make this point in their paper from a few years ago, which is the personalisation agenda entrenches the individualisation of risk and diverts public policy focus away from upstream determinants of population health. Now, I only read that paper this week, but I'd just like to say, snap. You know, I have had a very similar idea. I just haven't been able to articulate it as nicely as that. And so I think, you know, this is really key, is that when we start talking about granularity, we end up talking about individualization. And we need to really think about the fact that when we're talking here about population health, we can't forget about the population as a unit and all its messy complexity that that gives rise to. So if we are going to construct precision public health ethically, we need to focus on the things that are on the slide here. Where is someone's social position? How do they interact with each other? What are the social determinants that are impacting individual health? What are the equalities and inequalities? You know, where do all of these factors come from? How do they differ between different groups in society? Why do these differences exist, and what can we do about them in that particular group? And so we need to not immediately drill down to this granular, precise tailoring and just forget all about all this other stuff that's happening on top. And so we can't do precision public health by just scaling up precision medicine, because it won't work. And this is an absolutely ethical as well as an epidemiological imperative. So if we're going to think about some of these ethical considerations, how should we maybe do that? So that's the second claim that I'm going to make in my presentation, around some initial ideas about thinking about ethics when it comes to precision public health. So much of my field, bioethics, has emerged originally from clinical or medical ethics, because it was initially commenced by dilemmas that doctors faced. So one of the classic paradigm cases that kind of kickstarted our discipline, at least in North American context, was the invention of dialysis machines in the late 1960s. They had to make decisions about who would get dialysis and who wouldn't. But the paradigm that this is used, is used here, unsurprisingly, because it has come from a patient-professional relationship, is an individual-focused paradigm that has a strong emphasis, whether justifiable or not, on autonomy and avoiding paternalism, on promoting best interests, particularly when we're talking about children, on obtaining appropriately informed consent and respecting privacy. So there's some of the tenets of clinical and medical ethics. That's one tiny box around, 45 years of literature, or 50 years of literature. And all of those concepts are contested, and there's literatures on all of them. Having worked with Angus Dawson for so long, I can never say a concept anymore without giving a qualification about clarification and unpacking. So, this is the area that I've come from, and I acknowledge that, I will have implicit biases that come from the training and experience that I've had in that field. But bioethics as a whole has been heavily influenced by medical ethics. And so as a result of that, as I've already said, it focuses on these individual experiences. And also a lot of bioethics scholarship, whether explicitly or implicitly, draws on liberal individualist paradigms, very strong emphasis on liberty. And some of the literature in public health ethics still kind of rests in that paradigm. So what is it about collective or population issues instead? We need to think about these too. How do we try and address these interpersonal, interactive values and needs? So I'm just going to talk very quickly about two things, autonomy and empowerment. So just to kind of problematize them a bit, because precision public health talks about giving people this tailored risk information to allow them to exercise their autonomy and to empower them. And generally, the line of reasoning has tended to go, if something promotes autonomy, then it's great. Let's do that. Let's promote autonomy. But this is not necessarily the way that we should always go, because if we solely focus on promoting autonomy, we neglect some of the collective harm that can come from only aggregating individual actions. It can overlook that these so-called default accounts of autonomy, neglect the relational aspect, the fact that we all are embedded amongst a network of relationships with others. And it doesn't necessarily allow for critical reflection. So I mentioned Lisa Dive earlier. She's written extensively about this topic. And it also can overlook that sometimes so-called autonomous decisions can rest on problematic foundations, such as hype or technological imperatives, or the fact that we are just so conditioned to think that information is awesome and having more of it can only be a good thing. So just to say, autonomy, let's not just take that as a tick, great, let's problematize that concept. And it's not about removing autonomy, it's about using it assiduously and not only focusing on it, thinking about other things too. And with respect to empowerment, this word gets used a lot. I think the corollary of empowerment is responsibility and responsibilisation, which is a term that is emerging in the bioethics literature. It's possibly more prevalent in sociology. But ultimately, empowerment is about individuals exercising control over something. And in our case, it's a health intervention. And empowerment is often seen as good, and it's about giving power to those who may not have had it or may not have had the ability to exercise it. And it's about gaining knowledge, and it's this emphasis on gaining that knowledge and exercising your power. But again, it can move power from public to commercial institutions, particularly when commercial actors are very prevalent in a particular field. It can potentially overly responsibilise individuals, and that moves that responsibility from the state onto individuals. And it might neglect some of the constraints on choice that I've already alluded to. In this sense, also, we need to pay attention to concepts like health literacy and the fact that sometimes the health that we have is out of our control. So some of the most classic public health studies have showed your level of employment has a lot more to do with your health than anything else, or your postcode. So, the people may not have a say in designing the relevant view of health. And individuals may not have resources to manage this responsibility. And they may not also necessarily always want to do that, and it may not always be necessary. And that's quite a controversial claim. So let's leave clinical or medical ethics to one side for a moment and think also about public health ethics, and particularly some of the forms of public health ethics that are argued for in the literature. So, and this is not to say that precision public health can only be one or the other. I think the truth probably lies somewhere in the middle. But what public health ethics brings to the conversation is a more collective and communal focus, looking at some of those concerns for the public that I've already alluded to: equity, social determinants of health, broad public trust in health and healthcare, acting solidaristically and with relationality. Also, liberty, but perhaps downplaying liberty. But that is a tension in the public health ethics literature. There are certain forms of public health ethics that strongly emphasise protection of individual liberty and seeing public health ethics as an intervention that you should resist when it usurps individual liberty, or at least liberty maintains a legitimating role in when we can use a public health intervention. Others put that more to the background and focus instead on concepts like solidarity. So, as a bioethics scholar, I think we should be asking questions about precision public health, whether that be precision public health broadly or certain forms thereof, certain use cases. We need to recognise that these social contexts. We need to recognise the interdependency between these spheres, and that these social determinants, as I've said, are health determining too. And that all of these things are going to have a relevance when we start to try and be precise in our tailoring of interventions for groups and subgroups at population scale. We need to recognise that not all individuals are able to control these various elements. And actually, if we don't use it well, precision public health will actually make some of these existing inequities worse. And so we need to approach precision public health by asking questions to do with equity, reciprocity, and solidarity. So let's take a look at solidarity in a tiny bit more detail. So Angus Dawson and Bruce Jennings have written several papers on this, and in one of them they take a conceptual look at the concept of solidarity. I should also add, just for unsurprisingly, there is big debate in the solidarity world about what solidarity is. There's kind of two camps as well. So again, some talk about solidarity as the cost that you're willing to tolerate in order to accept and into something. I have affinity, probably because I used to work with him, with Angus Dawson, who takes a slightly different approach to solidarity, which is this notion of standing up beside. And it is this, we're standing up beside, we're standing up for, with, and as. And it's this identification and having moral concern for others. And that's driven by sympathy, understanding, wanting to correct an injustice or a disadvantage. And so it's about representation, advocacy, equity, mutuality, mutual respect. So that's not just speaking for, it's not just stepping in to kind of save, it's about engagement as well, and allowing people to have their own role here as well. But when their power imbalance means that individuals can't take that role, it's trying to make that happen. And in the paper I published, I talked about what that might look like in newborn screening. And so in precision public health, one of the things we need to do is, well, identify these groups. With whom should we be standing up? And how do we stand up for, with, and as those groups? And so how should a solidaristic approach guide implementation? And should it actually mean sometimes that we don't move as fast as maybe we have been? So in conclusion, I think we need to be careful about being distracted by omics technologies in precision public health, because they risk diverting attention away from other important interventions at the more structural level of health and healthcare. And an approach that perhaps combines attention to these more structural aspects and the more personal aspects is likely to be most effective, but we need to be extremely careful about when and how we use precision in public health. And we need to, if we focus too much on the technology, then we risk exacerbating problems that we already have. And it risks diverting attention from this focus on populations. And I think public health ethics provides a very useful way to start shaping how we might have some of those conversations and how we might approach precision public health. That's my face. I don't know why. Thank you so much. And I'll just pop the references up as well, just so you can see some of the things that I've been reading and writing.
Thank you, Ainsley. That was very interesting, and I'm sure we have lots of questions. I'd like to now invite discussant responses from Associate Professor Rosalind McDougall and Professor Jeff Craig to add their perspectives on their topic. I'll introduce our discussants. Associate Professor Ros McDougall is an ethicist based at the Centre for Health Equity in the Melbourne School of Population and Global Health. Ros originally trained in genetics and philosophy. She has a postgraduate degree Bioethics from the University of Oxford and the University of Melbourne. Her research and teaching focus is in the area of ethical challenges faced by health professionals. She's published widely in clinical and reproductive ethics and was selected in 2018 as one of the ABC's top 5 researchers in the humanities and social sciences. Ros has been involved in providing clinical ethics support in hospital since 2008. She's currently a clinical ethicist at Austin Health, and the Royal Children's Hospital. Our second discussant is Professor Jeff Craig. Jeff Craig is a professor of epigenetics and cell biology at the School of Medicine here at Deakin University, the Warden Ponds campus. He has a BSc in genetics and cell biology from the University of Manchester and a PhD from the University of Edinburgh and a grad cert in higher education and learning from Deakin. His research goal is to apply techniques of epigenetics and cell biology to develop biomarkers of health and disease. This includes a focus on the role of epigenetics in mediating the effects of early life environment on the risk for chronic conditions. Professor Craig has established many longitudinal cohorts, including the peri- and postnatal epigenetic twins study. In 2018, Professor Craig established the multidisciplinary network Gene Equality, which I'm part of. Its broad aim is to develop ideas on the technical, ethical, legal, and social implications of epigenetic research and testing. So I'll hand over to our discussants.
Thanks, Neera. I'd also like to acknowledge the traditional owners of the land, the Wurundjeri people of the Kulin Nation, and pay my respects to elders. Thanks, Ainsley, for a fantastic presentation. As I was rereading your paper before, in preparation for this, I was thinking to myself, I really must put this on the reading list for my master's students. It's such an exemplar, I think, of rigorous bioethics thinking and writing. So thank you for this excellent contribution to the field. I wanted to add 3 discussion points from my perspective as an ethicist who primarily works in clinical ethics, so providing hospital-based ethics support and really focusing on those individual patient care challenges. So my first question that I'd be really interested to hear further thoughts from Ainsley and from others is whether public health precision public health programs need public health ethics as a whole, like the whole set of concepts, or is it specifically solidarity that's the useful concept here? So I think Ainsley's made a very compelling argument that things like autonomy and empowerment are really insufficient as conceptual tools to think richly and carefully about this type of program. And I think from my perspective, it's very clear from Ainsley's work that solidarity is an important concept here. I think it's interesting to explore the kind of next level claim that public health ethics as a whole, the paradigm is what's needed, and thinking through, okay, what are the other specific public health ethics concepts and tools that would be rich and helpful in this approach? That's my first thought. My second thought is about clinical ethics and the scope of clinical ethics concepts. So maybe this is informed by my position as a scholar and researcher and ethicist who uses these concepts. So maybe I'm a bit defensive about the top box there on Ainsley's slide. But I wonder if clinical ethics, in fact, has a broader scope and is, well, if not sufficient, then more useful in capturing some of these more collective and social considerations that are clearly important to this type of program. So Ainsley highlighted the need for interpersonal, interactive values, and I'm wondering if there's more there to offer in a clinical ethics paradigm than the more kind of autonomy-focused ideas. So I think, to me, one of the real strengths of Ainsley's presentation and the paper, which I would commend to you, is this breaking down of the silos. So instead of thinking, okay, here's the clinical ethics box, here's the public health box, thinking in terms of the concepts within both of those frameworks and which concepts are going to be helpful for thinking about a particular program. And I think that this breaking down of the silos is really important and timely. So I've seen this in my work in hospitals during COVID, where suddenly a public health imperative has been really shaping clinical care. So principles like collective benefit have been impacting on the delivery of care to individual patients in a way over the last 2 years that we haven't seen before. And I think that some clinical ethicists would see this as new concepts shaping care. So similar to, I think, the more blended type approach that Ainsley's advocating. But I think other clinical ethicists would argue that clinical ethics as a framework already has a broader scope. So the principle of justice being a really central principle in biomedical ethics and one that's part of the clinical ethics paradigm. And I think for some clinical ethicists in the COVID context has been bringing that existing principle of justice into the foreground rather than taking a kind of blended approach. So I think that's in breaking down the silos, thinking, okay, what's the full set of resources that we have conceptually at our disposal? So that's my second thinking. Does clinical ethics have a broader scope and more to offer here? And then my third point is a future-focused one, and perhaps the next project for you, Ainsley, is thinking through, okay, who are the practitioners who would be designing and particularly implementing this type of precision public health program? And what's their ethical orientation? So what's the way that they normally work from an ethical perspective? What's their ethical training? What's their professional moral compass? And I think that this is a really crucial point, because in my work in hospitals over the past couple of years, with that public health imperative coming in around clinical care, it's been an extremely challenging ethical reorientation for clinicians. So for clinicians who've been trained and practiced in this paradigm of patient-centred care, advocacy for the individual patient, patient's best interests, to be asked, well, to have to incorporate a different set of values creates significant moral distress. So an example is around enforcing visitor restrictions. So for clinicians who can see the obvious public health importance of visitor restrictions and have been asked to implement those in their context, so difficult because it's so different to that usual orientation of family is good for patients. Having family around is really important to patient wellbeing. So clinicians being one I think beautiful encapsulation of this was a clinician who said, if it's right, why does it feel so wrong? So in the types of precision public health programs that we're considering here, thinking about who are the professionals who'd be implementing these and how can they be supported if we're asking for a kind of ethical reorientation or an ethical expansion in the kind of work that they're doing. So they're my three thoughts. Is it just solidarity or do we need the whole package? Does clinical ethics have more to offer? And who are the practitioners and how could they be supported? So thanks, Ainsley.
Thanks, Ainsley, and thanks, Ros. I've put down a number of rough notes during your talk, Ainsley, so I'm trying to track my own notes on my scribbled notes on this piece of paper. So let's go through them. First of all, I really enjoyed reading your paper. It gelled with a number of thoughts and that I've been having, including with discussions with other interdisciplinary experts about really to go beyond the expectations of people who study genes and genomes like me and ask about what are the practical barriers to implementing our lofty goals. And I think we definitely, first of all, I think we are guilty of overselling genomics and not really thinking things through. And I think there are a number of issues that we need to think about about the extremes, if you like, of precision medicine and precision public health. Certainly with precision medicine, what's not thought of enough is the technical barriers as Ainsley has discussed, there's so many steps to get, say, a biomarker, a genomic biomarker, from experimental stage through to the community stage. So many steps in so many years. We're talking 10, 15, potentially even 20 years to get all those steps. Then there's the ethical, legal, and social implications that we need to think about, and we often don't think about when planning these lofty goals of this precision medicine. And if you add on to that economic planning, that's a really interesting thing that I'd like Ainsley to comment on after I speak, is about those two approaches, alternative approaches. What's been the economic modeling of both of those? Precision medicine versus precision public health. Are they similar, or, as I suspect, is precision medicine a little bit more expensive? I should also say that that my mantra about what influences risk, all of our risk, is of course genes and environment, but also chance factors. And the proportion of influence, roughly when we're talking about general health problems, general health issues, 40% genetics. This is within a population. 40% genetics, 10% environment, and half of the influence of our health is chance. So with genomics, we will never be able to predict more than 50% of our risk for health. So there's a whole lot out there that we won't be able to do. Having said that, if we're talking about when researchers write about environments, they say, oh, but that excludes extreme environments. But then if you actually look at the number of people in Australia and around the world that do have extreme environments, it is not low. These are written off by researchers in my field. And certainly, you can potentially say that up to 40-50% of people in the world have experienced, at least 40-50% have experienced extreme environments. So that proportion of variation explained for many people will be much more than 10%. And so that's why these kind of public health interventions will work to some extent if they cover everyone, including those with extreme environments. It's interesting, the issue of liberty versus population. It reminds me, in fact, I only found out last week that the phrase bootstraps was developed by Rudolf Erich Raspe, a German researcher, who basically said it means it's an impossibility. We're asking people, especially those less able to do so, those without agency, to pull themselves up by their own bootstraps, which is impossible. So we need a way to actually, I think precision public health, or public health in general, is aimed at helping everyone, including those that don't have the agency. So I do understand that reason to tackle structure and not put too much into the agency. Only some people have that agency. Also, a couple of other observations. One is that precision public health, the first time I was reading Ainsley's paper, I wrote down the word utopia. It sounds like one of these ideas that's so lofty that it will be impossible. And it also then got me thinking about actual recent situations. Could we model precision public health versus personalized medicine? And I wonder if Ainsley could maybe comment on these. One of the examples would be, of course, COVID, and how we've dealt with that. What's been the approaches that have worked? And to me, that we've only recently started to talk about genetics, about those that may be resistant. And it seems to have been a general aim of precision public health, but I think it's kind of fallen flat on its face. And second, a small recent example here in Victoria, with the Victorian government making kinder preschool education free to all. And to me, that's an example of a general kind of public policy change based on scientific evidence that the first 3 or 4 years of life are the most important, and we should support children in that role of life, in that time of life. And finally, I guess another question is, to what extent does precision public health lead to a fear of surveillance with all that data being collected and people being tracked? So those are my hopefully not too disparate observations. Thank you.
Thank you for those incredibly generous comments and for also taking the time to read my paper. It's always, I don't know, I've been in this game a long time and I still get excited when people tell me they've read my work. It's nice to know that I'm not writing into the abyss. So Rosal, you've made 3 points and they're all really good questions, and I've got kind of thoughts about all of them, some more developed than others. Regarding public health ethics as a whole, that was your first point. Is it just solidarity or more broadly? It's broader in my view. And the reason I tackled solidarity in the paper I wrote and then stopped, not least because the word limits, and that paper was such a monster anyway. It was giant and I was trying to pack in way too many things, and it took me forever to write, and I was writing it during one of the periods in which I was writing it was during one of the COVID lockdowns and homeschooling, etc. So that was the one that I think stuck out to me the most, but that was just because it appealed to me, not from any particular objective normative reason why it's superior to anything else. I also, I've been in bioethics a long time, but this whole literature was fairly new to me until relatively recently, a few years now. And so it was the one that I just found I wanted to work it all out and get really stuck into it. But I also think obviously equity is key. I think concepts like reciprocity are also really important, but also just the kind of ways of thinking that taking a public health ethics approach gives you, in the sense that it allows you to frame questions in a particular way that maybe, again, though leading into your second question, typical approaches or certain approaches in clinical ethics don't always lend themselves to. So, which I think hopefully that addresses where you're going from. I think there's lots more to do here, and it doesn't only have to be me thinking about this. So your second question was, was I being a bit mean to clinical ethics? And I was thinking about that as you were saying it, and because my sort of claim there was drawn from both that paper I wrote, but also a paper I did with Lisa, the one I mentioned around population carrier screening and whether a clinical ethics or public health paradigm is the most appropriate. And we argue that actually it's somewhere between the two. And I think for a lot of precision public health, that is going to be true as well. And in the paper I wrote that kind of spurned this seminar, where I focused on newborn preventive screening, I didn't tackle clinical ethics as a whole necessarily, or at least I tried not to, because I just don't think that's feasible. It's really hard to do that. But I did want to make some points about autonomy, because I think for me at least that's where you see that concept being used in a really thin way. You see that concept being used in a way as a sort of ethical trump card. And so I wanted to really go big on autonomy in that way. So I think you're right, and I think maybe I'm right too. And I don't think we're maybe as far apart as maybe my presentation today might have alluded, in the sense that I think there are absolutely ways of thinking and doing in clinical ethics that will have relevance in this context. And the task is to articulate those clearly and to use them well. And I think sometimes clinical ethics scholarship, or scholarship that's in that area, doesn't do that well. And I'm often writing in the margins of things I'm reading, individualistic, or you're just thinking about liberty. And so, I kind of wield my red pen and in the dark at night usually. So I think, for me at least, I think we need to capture. I think I'm just actually probably repeating what you said, which is we need to think about those bits of clinical ethics that are important. And then your third point is about who should be involved. I actually don't know. I haven't thought about that. It's a good question. And I think it's a question around procedural fairness and transparency. And it's probably also a question about engagement. And there are lots of people who are super clever and are going to be able to think about that very likely better than I can. But I think it's important that we ask that question. Who are the people that we want to have involved here? So I might just park that for now, but I'd be really interested maybe to hear what others in the audience think as well. So Jeff, you raised a series of points, all of which I agree with. And I think what your comments highlight, if I can try and summarize them as well, is to say that a lot of the ethical debate here needs to be rooted in a really pragmatic context as well. And so it's about, finding all that messy complexity and working out a way to bring it into how we think and reason in the ethical debate too. And there were sort of one or two. I think the economic planning question, I'm going to completely fail to answer it because I just simply don't know. I think, this is a completely intuitive answer. I think maybe deceptively precision public health might be cheaper, but I think what you also need to count there is the knock-on effects of sending people back into the healthcare system. But maybe a cost-saving element of precision public health could be de-implementation of certain screening interventions if we know that they're not going to be effective in that particular group. Whether that particular group accepts that is another question entirely. My colleagues in Wollongong, whom a lot of you will know, Stacey Carter and her group, have done lots and lots of fantastic engagement work where they've found that people really don't like screening being taken away once it's been given to them. And a colleague of mine at Sydney, Kate Dunlop, is looking at that in the context of melanoma screening as well, for example, or other forms of cancer screening. Because it's very hard for us to resist this idea that a test is not something we need. So I think, obviously that economic planning needs to be done and the outcomes of that need to be factored into ethical debate. I also think, because you've mentioned this, for me at least, I think there's a lot of unexplored territory around ethics and health technology assessment, what the concept of value means when we're not just talking about economic value. I've got value genomics ethics written on my whiteboard at work, staring at me guiltily as an unexplored idea that I'd like to get more into. So I think, there is a question of cost, but also what do we mean by cost? What do we mean by value? And who gets to articulate that? I really liked your point about chance. That was such a nice articulation. I don't need to add anything to it other than to say I agree. And I think it's really important that keeps getting mentioned in this debate. And I also liked your bootstrapping point, and I agree with it. Your utopia point is such an interesting one. And I actually quickly Googled bioethics utopia because I know of a few colleagues in the field that have had kind of projects around this for a long time. And it's just such a big, hairy question that I think lots of people, it's one of these kind of lifelong things. It's the book that's never written, the project for retirement. But there is a bit of literature around what utopia means and its relationship with bioethics. It's not a literature that I'm in, but it is out there. And so maybe a question could be synthesizing that and looking at what that might mean when it comes to precision public health. And I think your comment about surveillance is a really valid one as well. And it speaks more generally, I think, towards big data and where we as a society are going with respect to that. And I think for me, the key points here are transparency and trust, but meaningful trust, like actually, using that term in a very rich way to bring populations along with us. And it's I think COVID, again, has kind of allowed us some of that language. It's given people a way of grasping that they may not typically have had, because we all made significant personal sacrifices to try and prevent collective harm. And I think maybe, I wouldn't say that we always had the trust of our governments in this pandemic and it's not over yet, but I think that type of transparency and illustrating that thinking is really important. So I'll stop there and open it up for broader discussion.
Might be best, I don't know if you stay there for the questions, and then open up to the floor for questions. Questions? Emma?